Well, hi everyone. My name is Mark Held. I'm one of the psychologists over on One Rehab. I'm primarily in the spinal cord injury unit, but I also kind of float around to the burn unit and the traumatic brain injury unit as well. And so today we're going to talk a little bit about adjustment after spinal cord injury. So just to begin with, I have nothing to disclose. I have no affiliations with anything I'm going to really discuss in this presentation. I'm going to at the end talk about a few different referral places, a few different resources, and Santa Clara Valley Medical Center doesn't endorse any of those, and they're just kind of for you guys to do further research, kind of look into seeing are some of these things something I would be interested in doing. So.
Are you familiar with our peer support program?
Yep, I'm familiar with the peer support program. Yep. So just kind of a little overview. We're going to talk a little bit about psychological concerns that can occur after a spinal cord injury. We're going to talk about treatment options. I'm going to go over some different resources in the community, and I'm also going to talk a little bit about how technology can help change the way we look at mental health and behavioral health after an injury. And then we'll have some time for some questions. So, all right. I'm not quite sure why this is no longer working.
Can you try to aim it over here at the computer?
Yeah. Not working at all. Yeah, of course after I said technology, this happened, so.
Okay, so let's see real quick. Unless it's the battery, but I'm going to, hopefully that's going to miss. Okay, so something happened and it's not working. So I'll just let me know and I'll.
Okay, yeah, no problem.
Next slide.
Yep, yeah.
Oh, you know what, Mark? Do it now. Sorry.
Oh, okay.
Thank you for that.
You're right. Okay. So the best part of this overview, though, is that I was told that there's pizza. So I'm quite excited about that as well. So I hope you guys are too. Functional, psychological, and socioeconomic changes can occur after a spinal cord injury. People are facing new medical concerns. They're facing spasticity. They're facing muscle spasms. They're having bowel and bladder changes. They're dealing with inability to complete certain activities of daily living. They're having changes of independence and sense of control. They're going through relationship and role changes. They're going over grief over the loss of their previous functioning. They're going through pain sometimes. And they're dealing with a lot of different medical costs. And when we think about this, and sexual health concerns. And so all of this compiles to the potential to have a lot of risk factors involving psychological developments. And so there's a lot of different patient stories, and you guys in your peer support group, I'm sure you guys talk a little bit about how everyone's processing through some of this. And so I found this New York Times article helpful. They went through different patients who have experienced different spinal cord injuries and talks a little bit about what they went through and how they processed through it. And so there are resources out there if when you're not at your peer support group, you need encouragement or you need other things to talk about and look up. So this is a good example of that. And I'm not going to really talk a lot about different individual patient stories because everyone does have their own individual things that they're dealing with. And so I'm going to talk a little bit about the risk factors like we talked about and then go into how can we treat some of these things if they are occurring. And so when we think about acute rehab, one of our main focuses is how do we improve quality of life. So this major event has happened and how do we help the person problem solve through it. So I'm going to kind of separate that initial concerns in acute rehab, and then I'm going to talk a little bit about more long-term concerns and risk factors and how do we manage those and how technology can play a really big part in that. And so when we think about initial concerns from a psychological perspective, there was a study that looked at 600 different patients from several different model systems, spinal cord injury acute rehab programs. And what psychologists tended to do with those people during those initial times are helping them process through their emotions, talk about emotional adjustment with them, help them with different family coping and individual coping, and talk about how do we educate the person to focus on their recovery and their adjustment to their new level of injury and their functional level that they're experiencing right now. And things that we think about in our rehab program, we follow a lot of those different things. And so my initial view of helping people is making sure they understand what happened to them. Do they understand their level of injury, where their spinal cord injury occurred? Help them assess, are they a harm to themselves? Are they a harm to other people? Help them work on identifying their feelings. How are they processing through this? Help them evaluating, do they have any cognitive problems because of their injury? Looking at what's their support system like? What is their historical health concerns and historical behavioral health concerns, and how may that be impacting their current level of functioning? Also looking at their substance abuse, identifying strengths to help them move forward, and then also helping to develop some sense of motivation to help them move forward so they can keep processing through what they're experiencing. And so from different psychological theories, people look at it in different ways. Sometimes people look at it through the stages of grief, and so what that looks like is initially after an injury, people can go through different phases of shock or denial, depression, anxiety, anger, a bargaining phase where the person thinks about, what if I had done this differently? If I had been a better person, maybe this wouldn't have happened. And then eventually people get to a level of acceptance and a level of adaptation to what they're going through. Another theory is looking at it from a developmental model, in that the person is now having to retrain their sense in regaining a sense of basic trust, regaining a sense of autonomy, and regaining a sense of initiative and moving forward and trying to move through what they're experiencing. And then the last theory that psychologists tend to really look at is the individual difference theory, and that is that basically people's premorbid personality, their premorbid how they coped with things is really going to impact how they are going to work and move through this new injury that they've experienced. And, yep. So by premorbid, I mean how are they before their injury? So what were they going through before? How did they normally cope through different things? Did they talk with friends? Did they talk with family? Did they tend to withdraw socially, things like that? So how did they kind of deal with things? And looking at, are those some good coping strategies that we can really utilize now and help them work through this? Or is that something that maybe we can help teach them some new skills? Yep, before whatever happened, yep. Okay. Any other questions on that? And so sometimes it's helpful to actually look at it as a whole, where these things can be going on all at once, in the sense that people are going through different levels of regaining sense of trust, but they're also going through maybe some anxiety, or they're going through some anger at the same time.
Developmental theory, is that various stages?
Yep.
Another very common thing?
Yeah, it's another kind of common thing about how does the person process through what they're dealing with, and so this is another common theory. So the question for the people on the teleprompter was, is that developmental theory something other psychologists use? So yeah, it's something that people look at. So any other questions on that? All right. And so during that initial stages, some of the things that we're looking out for are adjustment disorder. And what adjustment disorder means is just that the person has been experienced a major stressor in the past 3 months. It's causing marked distress, and that there's a certain level of impairment in their social, occupational, or other important area of functioning. And so that's really subjective. It's basically if another person in a similar situation had gone through this, would they respond similarly or not? And a lot of times this looks at someone having intense depression or intense anxiety and what they're going through after the injury. Acute stress disorder is a precursor to what post-traumatic stress disorder. And so what that means is that after an injury, sometimes people can have a trauma response, especially if they were in a car accident, if they were in another life-threatening injury. And so the things that we're looking for in this acute stress disorder is, are they having intrusive symptoms, so nightmares, some type of distressing memories throughout the day? Are they having negative mood, whether it's negative emotions, or are they unable to experience positive emotions? Looking at dissociative symptoms, so what is that? And that means basically the person is having an altered sense of reality. So sometimes people explain that as they feel like they're outside of their body. Avoidance symptoms, so they're trying to avoid the accident or things that remind them of the accident. Arousal symptoms, so being easily startled, jumpy, irritable, angry, having difficulty with sleep. And so these symptoms usually occur 3 days after the injury occurred and less than 1 month after the injury occurred. And when we think about some of the long-term concerns that we're really looking out for, after a couple months, if the person gets home, that they're getting back into their daily life, what are some things that we're really looking at to kind of monitor and evaluate the person? And so that is, we help working on aiding the individual at reducing their risk of developing something more severe. So it's normal for someone to have depressed mood, to go through those stages of grief after an accident. But if that's progressing for a long time and it's really impacting their sense of self, their sense of moving forward, we want to make sure we can help treat those people. We work at how do we increase their sense of social support, so things like incorporating them into peer support groups, connecting them with online support groups, making sure that they're still doing activities that they used to do, so whether that's going to church, going to sports games, getting out and doing a lot of the activities you guys do with recreational therapy and in peer support groups. Normalization of experience, helping them work through difficult feelings of being out in public. Reinforcing progress, so reinforcing progress that they're working on in OT and PT in their social life, in their work life. Introducing new activities. If they've had a head injury, helping them deal with their head injury through some cognitive rehabilitation, which is a retraining process, teaching the person different cognitive compensatory strategies, so how to compensate for any sort of cognitive difficulties that they may be having. Ensuring that the person's following up with all of their medical care and completing self-care activities, so making sure that their bowel and bladder care is being kept up, that they're following the proper recommendations from the doctors. And the last one, monitoring and assessing for risk of harm to self and others. And so some things we look at later on, a few months after the injury, is the person having a depressive episode. So what that looks like is for at least 2 weeks, they're having depressed mood, they're having decreased interest in activities, there may be changes in weight or appetite, changes in sleep, fatigue or loss of energy, psychomotor slowing, decreased concentration, thoughts of suicide or attempting suicide. And major depression and suicide are two of the biggest risk factors that we're looking at. It's estimated in one study I looked at that out of 9,000 people that they looked over a course of 10 years, I believe, 50 had committed suicide over the course of the data review. And so the highest rates of suicide occurred between 1 to 5 years after their injury, and for younger adults. And so, yep. Oh yeah, the normal rate would be less than that. And so for the depression rate as well, the risk is about 6 times as higher than the normal population. And so particularly over this initial period, the year to 5 years after the person has had this injury. We also look at what's their anxiety level. And so one of the disorders we're looking at is what's called generalized anxiety disorder. So worrying about different areas of their life for more than 6 months. It's difficult to control the worry. People may be restless, be fatigued, have difficulty concentrating, be irritable, have tension, or have sleep disturbance. And then for the criteria for post-traumatic stress disorder, it's the same as acute stress disorder, but the symptoms occur for longer than 1 month after the injuries occurred. And so kind of the main point of this talk is thinking about sometimes given that people are at increased risk, sometimes people need to be aware of what are the different treatment options for some of these different things. And so that's kind of what I wanted to really focus on today. And so pharmacological options or medications are things that people can take, and there's been a lot of research to show that medications can help improve mood, reduce anxiety. If you're having nightmares after a traumatic experience, there's medications that can help with nightmares. Psychotherapy, which is what I'm going to focus on mostly. We'll talk about that in a little bit. So talking with somebody, working on different strategies to help, like we talked about earlier, regain that sense of control, work through developing new coping strategies, making sure people are connecting with different support groups. And then peer support group, like you guys are doing here, is another really great way to work through some of the feelings that people are experiencing. So learning through other people who have gone through this process, hearing their stories, can really be beneficial to people. There's a lot of different self-help options out there, and there's a lot of different ways people can integrate back into the community and find social support systems. And the main goal is to reduce symptom severity, increase sense of self, regain the sense of control, and find acceptance in the current level of functioning or embracing pleasant activities. And so different forms of psychotherapy, there's a lot of different models. Every person is an individual, and some people respond better to certain therapies than others. And so the one that's really been shown to work in treating depression, anxiety, trauma response, and helping people process through difficult emotions is what's called cognitive behavioral therapy. And I'll talk a little bit about that on the next slide. And that's been really shown to work at both treating initial symptoms, but then also helping prevent the reoccurrence of symptoms. So a lot of times medications can help reduce symptoms people are experiencing, but then they can come back after the person stops medications. And so therapy is a really good way to help teach someone a new skill to help them reduce symptoms, but then also help prevent more symptoms from recurring in the future. Another type of therapy is called cognitive processing therapy or exposure therapy. So after a trauma response, research has shown that all those symptoms we just talked about, those avoidance, are what really reinforces and really keeps the person experiencing those symptoms. And so these forms of therapy follow a protocol to help the person expose themselves to the negative emotions they're feeling, to the reminders of their trauma, so that their anxiety may start down here, start way up here, but then over time it decreases through the protocol that they're working on with their therapist. Mindfulness is a new form of therapy. It really takes its root in meditation and relaxation strategies and helping the person develop a sense of calmness and being at peace. And acceptance and commitment therapy is also a fairly new form of therapy. I think it was developed in Australia. And that really helps the person work through whatever they're dealing with, depression, anxiety, and come to some form of acceptance. I'm not the biggest fan of that kind of therapy because it uses a lot of metaphors, and I don't really like metaphors. I like cognitive behavioral therapy because it's very problem-focused and it's very concrete. But some people find that's very helpful. And so what is cognitive behavioral therapy? It's based on the model that the thoughts you tell yourself affect the behaviors that you're dealing with, which affect your emotions. And we really focus on, first, what are some behavioral strategies that we can do to help the person regain a sense of control, to get back into their community, and then what are some of the thoughts they're having. So some of the thoughts are, I'm in a lot of pain, I'm never going to get through this. So how do we help them restructure that thought in a very structured way to help move through that pain, to help work through it, to regain that sense of control over that situation? Because a lot of times the thoughts that we tell ourselves may be extreme or exaggerated, or they're based on evidence that doesn't support those thoughts, which then makes you feel anxious or makes you feel down or makes you withdraw behaviorally from other social events. And so the idea is that all these are connected, and we try to tackle the thoughts and behaviors because that's going to impact how you're feeling. And so how many people here are familiar with telehealth? All right, okay, Robert. I don't know if that counts, Robert. Well, so telehealth is the use of a video conferencing device to connect with a health provider from the convenience of your home. And when we think about technology, this has really been a great way that a lot of both medical providers and mental health providers have been starting to connect with patients. So with telehealth with spinal cord injury patients, there's been studies on helping to monitor their wounds, to monitor their pressure ulcers, to connect them with making sure that they're keeping track of their diabetes. And so it connects you to your provider via some type of video conferencing system, so your phone, an iPad, The VA has some special devices that they use to go back and forth, and it's slowly been integrating into mental health. And so with spinal cord injury patients, there's been a lot of research looking at how do we do motivational interviewing to help keep the person moving forward and working on their medical concerns. How do we help with education? How do we help with that connection to the community? And it's just starting to get into looking at how do we implement now some of these protocols like cognitive behavioral therapy, acceptance and commitment therapy over this processing system that we have. And so if you're interested in learning a little bit more about this or connecting with someone, it can be a really great way to connect with someone. So the benefits of this with someone who's had a spinal cord injury patient is that you get to stay at home. So you don't have to get out of your home to do this. You just have to have the system that your provider is utilizing to stay connected. And so there are providers in the San Jose area that are doing video counseling or telehealth. And so this is taken from Psychology Today. I just pointed out, works a little bit, but not really. So I listed, if you go to the website, so you go to Psychology Today, and you go to the side, it has a list of different things that people can think about working on. So if you're feeling depressed, if you're feeling some of those symptoms we talked a little bit about earlier, you can click on that. If you're interested in telehealth, you can click that button. I can't actually see that. And you can also list the different insurance provider that you have. And so it can give you a list of people in your area who have those certain values that you put in. And so this is one example from Psychology Today, and then this is another example from goodtherapy.org. And so it's the same thing. They have a system on the side where you kind of input what you're looking for. And I think this one's listed as, oh man, I can't see it from here. Online coaching or phone therapy. And so it's just another way to kind of help search for people in the area. And so these are examples of some of those teleconferencing systems we talked a little bit about that people can have. I think this is the one at the bottom that they use at the VA. And so if you're interested in using your insurance, calling your insurance provider, and they may have a list of people who are currently doing telehealth services. Looking at those two websites I got, doing a Google search. The VA has their own specific website for telehealth with spinal cord injury patients. So if you're a veteran, fortunately Santa Clara Valley Medical Center is not quite up to date as the VA, so the VA has a really great system for some of that, and so that's the link for that service through the VA. And then by connecting with your local hospital, we're actually thinking about starting a telehealth study here, looking at that. And so we're in the works of doing that. And then different phone apps on your phone can help connect you to different online therapists. So I put just one example, the Talkspace on there. There are lots of different ways to keep this peer support group going. Another way to help work through and process these emotions. So the Christopher and Dana Reeve Foundation has a lot of great resources. There's both a phone number to call or by looking through their website. You can find someone within your local area. I did the Disabilities RS chat room last night. There was about 12 people online. We had a really great discussion, and they really seemed to like that service. When you do a Google search, there's 10 other different websites, and they seem to all have people on them chatting. So it's another way to stay connected with people. And that last one is just another example of a chat room that we found. Self-help, there's a lot of different phone apps that people can utilize. So if people are having symptoms of post-traumatic stress disorder, there's a phone app called the PTSD Coach. And so what this app looks like is it helps you track, well, how are you feeling, how are you doing? And then depending on your responses to some of these different things, it will give you an example of what can you do to help yourself. Should we practice a relaxation strategy? Should we practice behavioral activation strategy of getting out of the house, of going to do something? Do we need to have you call one of our suicide prevention hotlines, or have you call one of our support staff? And so it helps just kind of prompt you and connect you to help in this self-help way. For anxiety, relaxation has been really shown by research to help reduce anxiety. And so there are two pretty great relaxation strategy apps, so Headspace and Stop Rethink. And The two different types of relaxation strategies I would really recommend would be the deep breathing or the guided imagery. And what guided imagery is imagining some place that you find safe and walking yourself through the different sensory experiences that go along with that. So what do you see there? What do you hear there? Do you taste anything? And practicing the deep breathing along with that helps really calm you and relax you. And then for depression, I've just put another app that's very similar to the PTSD Coach. So walking yourself through how can I monitor some of my symptoms, and it prompts you and gives you some examples of what can I do in that given situation. And the Christopher Reeve Foundation has done a really great job of putting out a list of different apps that someone can use on their phone to help with speech, to help with communication, to help with mobility, to help with just utilization of your phone in general. There's also a lot of cognitive retraining apps, and so like Luminosity is pretty great, and there's some other ones. And the idea being that how do we integrate our phone and our iPads and these other devices to help with some of the concerns we're dealing with. And so this is just a list of some of them. There's also a list at the Shepherd Center where I got this list, but a year ago the Christopher Reeve Foundation came out with a list of, I think, 49 apps that have been really helpful. And so it's just going to their website and looking it up. And how many people have utilized adaptive technology in part of their recovery? All right. What are some of the things that you've done?
Dragon.
Okay.
Paralyzed.
Okay. All right. So the person used different voice recognition technology. And so there's a lot of different things out there. If you used to be a hunter, I think that's Christopher Reeve himself in the corner right here, getting out there and hunting again. If you're working with your PT and OT, finding out if you're eligible to use exoskeleton to help with gait retraining and muscle strength. Finding ways to help with vocational retraining to be getting back to work if that's a goal of yours. Different voice conferencing systems to stay connected at school, with friends, with social media, with ways that are going to keep you activated and engaged in the community. Getting back in fishing. With our recreational therapy department, they practice fishing here, and they have a lot of different great adaptive tools and ideas for someone to think about doing. And so if you're working with an occupational therapist or physical therapist, some ways to think about integrating these different adaptive technologies into your own care is by talking with them, seeing what's out there. The Independent Living Center has access to a lot of different things, and I think it's on the next slide, but let me look here. Yeah, so I put, I hope Robert can send this out to people if they're interested, because I put this link that will have each county's Independent Living Center listed. So you just click on your county, and it will give you their address. And so the Independent Living Center is a really great resource. Are people familiar with that? Okay. They offer advocacy, peer support, adaptive technology, vocational training. It kind of just depends on the center, but they all have very similar things. And in Silicon Valley, I just put our closest one and the contact information for that on the bottom. And then FacingDisability.com has a list of about 50 what they consider to be reputable sites that talk about specific adaptive technologies, and it kind of goes by category. So this is if you're having a concern with speech, if you're having some difficulties with trying to utilize your phone, utilizing other technologies, what are some ways and how can we do that? And the Christopher Reeve Foundation has a 400-page book that you can access via PDF, Kindle, or they'll mail it to you for free. And let's see.
I know it's a little hard to read from Orange, but I can go ahead and send it out.
Yeah, Robert said he'd send it out, and I'm having trouble reading it too at this angle. Man, I need some glasses. Anyway, all right. And thinking about this, all these things cost money. Money is hard to come by at times, and so California has a really great program that helps distribute assistive technology and adaptive technology to people through their exchange program. And so I ended up listing that program. You can either email them and fill out, you can either go to the website and fill out a form, or you can call them and they can help connect you. And so there is one located in Milpitas, I believe. Has anyone been there? No, okay, so it is a center where you fill out this form, you ask them a little bit about what's something that you may need help with. Do you need some adaptive device to help with speech? Do you need an adaptive tool to help with getting back to work? And they will go through their database, see if they have one on hand and let you borrow it or check it out, or they'll help connect you with someone in the community who can either lend it to you or give it to you for free. And so it's something to really think about. What is something that I want to do for myself? What's the goal I have? Is there a way that I need help connecting myself to complete that goal? And talking to this person. They're also, it's on the website. I didn't look it up, but maybe we can look it up afterwards. So, yeah, it's ability tools, and then.
Is that separate from SCI?
Yeah, so website you can connect through the Silicon Valley Independent Living Center, and they can help connect you to it. But it's a separate entity, from my understanding. I'm looking at the form to fill out, and it's just this one-page form. It just says, who are you, what's going on, what's something that you're interested in getting. And then people are really getting into the idea of personal fundraising options. And so things like GoFundMe and helping and carrying hands. I can't read this from here. Anyway, you care. So if there's a project that or something that you really need assistance with getting, these are two different websites where people go and ask members of their community to help them fund them, or you mail it out to your friends and family, and they can help donate it to you. And so it's another option to help kind of pay for some of these things. Some more local resources just in the area. If you're not interested in looking up a provider through Telehealth, the Santa Clara County Behavioral Services, we have a general access line, and they can kind of help connect you to an in-person provider and give you a list of all their different contractors they have in the area. I just put the suicide prevention line on there. So if you're feeling like you're having thoughts of wanting to harm yourself or feeling down, the crisis line can help connect you with people in the local area as well, or just have someone to talk to if you need someone to talk to in the immediate moment. And then to kind of summarize this, so after dealing with a major life-altering event, your psychological well-being can really be put to the test. And so there are a lot of different ways, if you are experiencing different behavioral health concerns, that we can help you, whether it's through going in and seeing a provider, through telehealth, through getting you back involved in the community, through peer support, through social integration. There's lots of different ways to help you. And so technology has provided a few new venues for us to kind of think about considering and keeping up with our overall psychological well-being and health. And so I wanted to leave enough room for questions so people could ask me questions. So I kept it pretty general, I kept it pretty vague so that if people were wondering about something, we would have this time to talk about it right now. Yeah. 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 Yep, I've been here about 2 years. So before that, I was at the San Francisco VA and the Palo Alto VA. Yeah. Yeah. Yep. So the question is, talking a little bit about the peer support group. And so another one of our psychologists throughout the One Rehab stay, when people are participating in the acute rehab process, she leads our adjustment group at that time. And so it's on Thursdays. It's not on the time of the peer support group. But I think in the past she's participated in the peer support group a little bit. And so I have not. Nope.
Did you ever have a chance?
Yeah. All right.
Maybe later give us feedback. levels. That's a good question.
Yeah.
You don't know for some people are fighting for years, and we're amateurs. Try and share the stories and experiences, and we don't have any time to get what they do is that's a place
Yeah. So the question for people online was how to integrate psychology into the actual peer support group meeting. And I think that. Yeah. All right. Yeah. I'm more than happy to talk to people or kind of go over things, and that's I think one of the reasons that I'm here today as well. So.
I love your first slide list of things that can be effective with the SCI.
Mm-hmm.
My first slide is just look at them some environment.
Yeah. So the question was just like in this slide that had the list of different things that can happen after a spinal cord injury. And I think that that's really important because there's even more things than that's on that list. And people experience those in different ways. So, and I think that's why I haven't been to the Monday night group here yet, but I really encourage all the patients who are participating in at least the one rehab program to go because providers sometimes have their own ideas about what's helpful. So, is this helpful? Is that helpful? And actually going and talking to another peer who's experienced it is even more helpful at times. So. Yeah.
So you actually talk to SCI.
Yep. Yep.
So you, the last few years.
Yeah. So we have.
How did that work?
Yeah. So a little bit more about myself. So I've been at the spinal cord injury unit for about 2 years. I was previously at 30 hours a week, and now I just switched to 40. And so throughout the time, it's about 10 to 12 patients that I follow at a time per week, and it really depends on kind of what they're going through. So some people, when we think about that model that we talked about at the very beginning, you actually asked a question about it, about what does premorbid mean. So sometimes people already have developed a lot of really great adaptive coping strategies. So maybe they've gone through a previous trauma, or they've really gone through experienced depression in the past. So they already have some skills maybe coming in that they're really utilizing. So maybe they don't need to be seen as much. So I maybe see them once a week or twice a week. Other people, right now I'm seeing somebody every day. It just kind of depends on what they're going through. And so it really focuses on, my big concern is really monitoring for risk. So is the person having thoughts of wanting to harm themselves? Are they really taking it with that sense of guilt, with the sense of blame, with whatever they're going through? Because those are big indicators that they may be having a more of a difficult time than some other people. Yeah.
And what happens after discharge? Have any follow-up?
Yep. So right now we're just inpatient providers, but we try to help set up. If we feel like that they would really benefit from someone, and I think that at least for the first couple of months afterwards, either people were started on medications while they've been in the hospital, or when they go home, they need to keep on those medications, or they feel like they need to keep seeing someone. We help connect them with. Each county in California has a list of behavioral health providers that the county provides. Otherwise, I give them resources for whoever in the county that they're living in, because we get a lot of people from North Bay or Monterey, Santa Cruz area that may be good providers for them to work with.
I've got 2 questions here.
Yep. Okay, yeah.
So what issues the most consistent one phase in dealing with SCI spinals?
Yeah, so I think in that initial phase, kind of one of the most consistent things is the person dealing with that loss of functioning. So really walking through that stages of grief. So what is the person facing? Previously they had these certain life goals for themselves, and they're in this point of their life where they're feeling like they're not going to be able to accomplish those goals. And so how do we as a team, how do we as myself as a psychologist help that person walk through that and realize that they can get back to going to school, they can get back to going back to work. And so it just may take some time, and it may take some adaptation, it may take some assistive technology, but most of the time people can get back to doing the things that they like. And so it's helping them work through those stages of grief and regain kind of that sense of what's the new normal for them. and realizing that that new normal is going to be different, but they're going to be able to work through it and keep processing through the goals that they have for themselves.
You want to go ahead and just read the second?
Yeah, so the second question is, how do you address issues the family and friends of the spinal cord injury survivor face and their processing of their loved one's injury? Yeah, I probably should have put on some caregiver resources, but throughout the time, helping make sure that the person does have someone in their life who's active and participating in the therapy can really both help the patient, but also help the family members feel like they're staying connected and they're involved. And there's a big role change for both the patient and the caregiver or the loved ones that they're going through. There's lots of concerns about sexual health, about intimacy, and helping them realize that there are ways that this can be adapted and changed, and people can still have those certain areas of love and connection in their life. And helping connect them to their own resources. So kind of walking them through that same process. What do they normally do when they're feeling stressed? What do they normally do when they're feeling down? Do we need to help connect them to continuing to do those things, but also maybe do we need to help connect them with other resources? So there's a couple of different resources in Santa Clara County. So one's called SourceWise. Independent living centers have some spousal support. Christopher Reeve has their own online spousal support system by going to their website. So there are different resources. It kind of depends on where the person lives or on what they're going through. Yeah, so the question is, am I the only psychologist on the unit? So no, there's 3 of us that typically follow the spinal cord injury unit. We try to take a primary team, so I'm mostly working with Dr. Cha. So if people are familiar with Dr. Cha. Yep, Penny is a psychologist who still works there. And then Marie Roman-Clifton is another one who's primarily on the spinal cord injury. Yep, so yeah, it's around, each team has about 10 patients on it at a given time, and so normally about just 2 people for that unit, and then we have 3 people on the traumatic brain injury unit, and then Penny mostly does burn unit, and then we cover peds and acutes and the respiratory center.
I have a question.
And then there are other psychologists throughout. There's a hospital psychologist that kind of covers the whole rest of the hospital. We have an outpatient neuropsychologist who helps with outpatient neuropsych testing if you've had a head injury. Each primary care clinic has a therapist who's working there. Some have psychologists, some have marriage and family therapists.
The question is, Mark, how do you feel professionally in terms of, because sometimes, with our peer group on Mondays, there's been a talk of censoring some of the things that we talk about. Mm-hmm. Like, how do you feel about that in terms of, do you feel that as a peer support, there should be things that we don't discuss?
So the question is, are there things in peer support group that we shouldn't discuss? And so it really depends on kind of what is being discussed. So when I'm going to use 9/11 as an example. And so after that, people did critical incident stress debriefing. And so what that was is getting people kind of together in a group and talking about their experiences. And so that actually, research showed, wasn't the best way to deal with that, because then the person, if they were in the same area or the same accident, then they gained new pieces of trauma. So they gained kind of maybe more details that they had either forgotten or not known about. And so it actually caused them to have more symptoms of PTSD. Yeah, so strengthened kind of the symptoms that they already had. And so what research has really shown is that that's not the best approach to do. So they learned a lot from that experience, is that more psychological first aid, to helping people really think about what did you do in the past, making sure all their comfort needs are taken care of, thinking about how we integrate those things that they used in the past to help them move forward, and connecting to someone for them to talk to if they need it. So I think it's good to kind of just preface that if someone wants to talk about what happened to them, and I think that that can be okay, because the likelihood of someone else going through that same injury is pretty slim. But it may be good to just kind of have a preface of, I was in a car accident and I'd like to talk about that. So if there is someone who feels like they may be triggered by just talking about a car accident, that maybe they don't have to participate for that 10 minutes. Maybe they can just kind of sit outside with someone else. So does that make sense?
Yeah.
Yeah. Yeah. Yeah. So I don't think it would be a problem if we'll do that. So we've led at the other VA, I led trauma support groups, and it was okay. So. Yeah. Oh, yeah. Oh, I think you've been waiting for a while.
How do you find that religious beliefs help people through their rehab process?
Yeah. So the question is, how does religious beliefs help the person through the process? And so I think that really, this is what I should have prefaced this at the beginning more. It is very dependent upon the person. And so if the person previously really responded to religion in the past, helping them process and problem solve through difficult life experiences. We have a spiritual care team here that I refer to them frequently. Sometimes I'll preface going into it, though, in my little consult to them, that the person is having a lot of guilt and shame about what happened. And if that's the case, helping that spiritual provider know that that's something that's really impacting their psychological well-being, and that's probably not something that they should reinforce. And so helping them see that there are other ways to view the situation or think about it, or helping the spiritual care person know that maybe forgiveness is something that would be important for them to work on.
Happen to be a spiritual care.
Okay, yeah. Yep, all right, okay. So you're a spiritual care volunteer. What do you think about that?
Finding that those who have a deep religious background find comfort and help when I see them, and be able to talk about their beliefs and how it's affected me in my own personal life.
Yep.
And telling them how my trust in God has helped me through my 40 years of spinal cord injury, and reading a devotion and prayer with them is very much appreciated.
Yeah, and so I talked a little bit about that devotion and prayer and being connected to the person and really utilizing their religious faith has really helped him process through it and help the person process through it. And I agree. And I think that it really is really dependent on the person, and I think it's encouraged if that's something that they've really done in the past. And
it is very person dependent.
Yep, it is very person dependent. And so I think it goes along with very similar things, kind of going back to that mindfulness or that meditation. So prayer has a lot of those components as well. It's relaxing the person, it's calming the person. And so just from that kind of psychological standpoint, it's helping to calm their body, relax them, so it can help them process through it. Sometimes people do mantras or do chants, do other things like that along with prayer, and so that can kind of be calming and relaxing as well. So, yeah, I think it can be a really great addition or soul provider for the person. So, yep. Yep. And there are a lot of religious-based counseling services out there as well, and a lot of churches that have support groups, so sometimes we help the person realize that they could go through their church as well. So.
What stats do you have survival of spousal relationships?
Yeah, what stats do you have on the survival of spousal relationships post spinal cord injury? That is a very good question, and off the top of my head, I do not have the answer to that. Do you have an answer to that?
I'll tell you my answer. The answer that I use.
Yeah.
When I was at the hospital here, I had a roommate who was crying at night. He was going through divorce.
Yeah.
Tried to console him. He said, "No, don't worry about it." He said, "If 9 years of bliss would have strengthened it. It was 9 years of hell, and this was the last straw."
Yeah.
You know, so I always tell people that often the SCI will amplify whatever was there before.
Yeah, he said that spinal cord injury tends to amplify whatever was there beforehand, and that's kind of been what I found as well, is that if there was previously some marital distress, that a lot of times it can be amplified. A lot of times it can be the opposite, and it can really bring the two people together. It really depends on what's going on, and that burden of care that the family member perceives that they have in processing through it. And so if we as a team, we as providers can help reduce that burden of care, usually that can be helpful as well.
The statistics that I've heard about families affected by disabilities in general, which could include families that have a child that's born with autism, for example, that the divorce rate is somewhere around 80%, whereas in the general community it's somewhere around 50-55%.
Yeah.
But with spinal cord injury specific, I don't have those numbers.
Yeah. Yeah.
Sounds close.
He said that it's about half of the population divorces on its own, but if you've had a kind of a severe medical concern, about 80%, or you have a child who's experiencing a severe medical concern, it's about 8%. But yeah, I'm not sure the statistics on that though. So I think it's something I could easily look up and send you guys the model systems, which hospitals participated in, and collects data similar to that. So I think it may be in their system. I just got to talk to Linda, who's one of the research psychologists, to look at that. So, yeah. How do you counsel spinal cord injury survivors concerned about dating? Well, that's a pretty great question. So, on our unit, we have had people patients who are both patients on the unit. They have started dating. Causes lots of drama on our unit, but it's very interesting. So, it's important to encourage sexual health and dating and intimacy, because that is a common part of everyday life, and that is something that doesn't actually get addressed enough in the general population. Actually gave a talk on older adults, just older adults in general, sexual activity, now that a lot of people are living in nursing homes or living in retirement homes, how the rise of STDs within those populations is occurring, because older adults tend to not use protection because they feel like they can't get pregnant, and so there's been a really big increase in that. And so it is an important part of everybody's life, and so it is something to talk about. There are a lot of different books on dating, on sexual intimacy. There's a couple of YouTube videos. Tram is our nurse who runs our sexual health meeting, one of the meetings that we have on Monday night group. So if you're interested in coming to that, maybe Robert could ask to see if you could come and join. It's once a month and they go over different adaptive technologies and different ways to help stimulate erection if you're having difficulty with erection, talking about sexual health, because a lot of times people can still get pregnant, and how do we problem solve and process through those things. So there's also a lot of different websites that just talk about how do I regain that sense of intimacy. And so I had one older adult couple who they used to hug and kiss all the time, and now they've just adapted that to they would rub cheeks because their spinal cord injury is pretty high. So how do you still regain that sense of love and connection to somebody? And sometimes it just takes adapting it in a new way. I think that there are actually spinal cord injury dating websites. Don't quote me on that. Has anyone tried those before? No? All right. Yeah. Yeah, there are Facebook groups, yeah.
The only people that I know they both have spinal cord injuries, that's where
yeah. How have people's dating experiences been? Yeah.
I met somebody actually.
Okay.
Actually, second.
All right.
For long-term,
Yeah.
So, friends, I started doing in 2006.
Mm-hmm.
It was interesting. It was hard because the injury was a little higher than mine, so I wanted to help them.
Okay.
Do things, and he said, no. So it was sort of a boundary between that. And I don't know, I guess I think being a woman, I wanted to help clean up the place and have a little bit of care. So that was kind of exhausting. But it was interesting. Unfortunately, he passed away in 2015. Learned a lot from him. He's been sure 40 years.
Yeah, thanks for sharing. We just had someone share their story. And I think in hearing that, it gives a sense of hope that you can still find love and you can still connect with somebody. And it can be someone who's also experienced a spinal cord injury.
I've had plenty of dating experience since my injury.
Mm-hmm.
I had plenty before the injury too. And the fact that I've continued to go through girlfriends after at roughly the same rate, one every 3 or 4 years, leads me to believe that there are factors other than the spinal cord injury. It does complicate things, as it does with any caregiver role. Things that I can do myself that is really hard. She can help me with sometimes, other times you just never do it yourself. And it's, just it's true of any spinal cord injury patient or anyone really. There's those issues to work out with family members and caregivers. So some added dimension.
Yeah. The individuals talked a little bit about connecting with, figuring out those role expectations and how do you kind of navigate those. And so that's something that he's really been working on.
You have a question here?
Yep. How do you provide support to non-English speaking survivors? VMC gets a lot of such patients. What do they get? Well, they get the exact same thing. And so we've had patients who are American Sign Language, and so we actually have a really great, another way we integrate technology is we have an iPad that's connected to this little stand, so it kind of looks like a robot, and so it connects you to American Sign Language provider, and so they do American Sign Language via the iPad and connect the person. If the person's having, if they're nonverbal, we use a communication board, and so what that looks like is a board where we help them spell out and connect. There are also some ways we can do that on the iPad. We have translators of pretty much every major language that are inpatient providers, but we also have phone translators if we don't have a specific language. And so try to, in thinking about the psychological aspect of what we do the same thing, do the same measures. So if it hasn't been translated in another language, using the translator to help translate it in the moment. And so sometimes it's a little bit different, but usually it's pretty the same. And then there's different normative data based on the person and what they're going through or the thing that we've tested them on.
So you do an interview with a patient with a translator?
Yep, we do an interview with a patient with a translator right there. Yep.
But it's still as effective or personal?
It really depends on the translator, what they're dealing with. So sometimes the person bonds with the translator, and so that actually can be quite a good thing. And I've seen them after work talking with them or kind of being very friendly with them. So that helps them with their recovery to have someone who in person who they can talk with. And sometimes it just takes a little bit longer, I would say. Yeah, so that's fine. Yeah. Yep, there aren't any bilingual psychologists here. Oh, I guess I take that back. One provider does speak Vietnamese, so.
Do you have access to lawyers or what used to be AT&T language line?
Yep, yeah, we have access to a phone system as well, and so I think they're trying to integrate it to making it all of it iPad. I'm not quite sure about that though. But it's pretty easy. You just connect. There's a phone on a stand if there's not an in-person translator that we have available. You just connect the phone into the patient's room, and it connects to a person who speaks their language. So, and a couple times I've had to use Google Translator. If it's just something I need to run in and give them something, I'll type it on Google Translator, we'll translate it, and they can read it, and then they just, yep, that makes sense. So there's a lot of ways that we're trying to integrate technology into our care. So
You gotta be careful, but sometimes they're not very accurate.
sometimes it's not accurate, and then if you connect with an in-person translator, then they yell at you for doing it. So.
I was actually in the unit one time, and I was trying to tell someone about peer support, and somehow in the translation, she thought that the other one got amputated from her son.
Oh, okay. Okay, yeah. He's talking a little bit about translation errors that have occurred, and they do occur sometimes. So, yeah.
How do you deal with the patient's possible response that, well, you're not in a wheelchair, you don't know what I'm going through?
So the question is, how do I deal with someone who's currently experiencing denial of their injury or kind of their functional level? Is that?
Well, not denial, but the fact that you're not in a wheelchair, so you have no idea what the patient is going through.
How does the person? How do I as a provider deal with that? So it is really dependent on the case. I had the same thing at the VA. You weren't in the military. You don't know what's going on, and so that's true. I may not know what's going on, but it doesn't mean that I can help you with what you're going through, or help connect you with someone who can, and helping them kind of problem solve through the things that they're willing to talk about with me or share with me. Usually the person will come around, or else they're willing to be connected with somebody else. So that's where peer support is very helpful, and connecting with somebody. I've emailed Robert a couple times and said I need someone who's more the same age. So sometimes people want to feel like they're just connected to someone who is the same age as them, who's going through the same thing, and that's been helpful. And it's usually older men who say that. Yeah, from my experience. But that's just me saying that. So, are there more questions?
Thanks, Dr. Howard.
All right, thanks, guys.